assume that we can multitask, I'm inviting Dr. Nash and Dr. Childs to come and join us by first a dialogue and then inviting us into that dialogue. Thank you.
All right. We're going to talk to each other a little bit and say a little bit about why we're interested in this topic. Before we decided I'm going to start, I just want to re-emphasize and reaffirm the important work that Paul has done, and all the work that Paul's been working with, the folks that he's been working with to do this good work. But our job isn't done yet. This has been kind of an inductive process. And we've discovered the areas that really do work. And of course, the ultimate goal is for these projects to be self-sustaining, but we're not done yet. And it's our hope, and we're working very hard on this, it's our hope that Paul in this project will continue on so that we can continue to establish these centers of action in ministry and learning as we collaborate with the healthcare community and the faith community. So keep tuned and keep interested in what we're doing, and we'll be really grateful for that. I got involved interested in health and faith, in part, typical story. I'm a son of a physician. Both parents were also, I'm Presbyterian, been Presbyterian since before the foundations of the earth. And both my parents were elders in the local Presbyterian church. Moved around a lot. My dad was a Navy doctor, so we moved around a lot. So it was almost natural that either I'd go into medicine or go into ministry. Of course, I went into ministry. My father said, I don't know how you're going to pay the rent. And I went into chaplaincy. After seminary, I didn't go to graduate school. I went into chaplaincy. And it was in chaplaincy that I understood that a critical illness is a spiritual crisis. Some of our more secular friends would say, what's an existential crisis? But it's a spiritual crisis. What is the meaning of my life? Where am I going? What is intended of me? When once I was able and now I'm dependent and hopeful that I can retain or regain my independence. That's an essential question of what it is to be a human, what it is to be alive, and potentially, and always, of course, mortal. Well, I went into chaplaincy and did chaplaincy in acute care hospitals and psychiatric hospitals mostly. And so I became very much interested in the history of this movement. And it's something that I think is really important. There has been a relationship between faith communities and the healthcare community really for quite some time. It went into kind of hibernation for a while. But in 1920 in Boston, there was a thing called the Emmanuel Movement, and it happened at Emmanuel Episcopal Church. And the priest there was Elwood Wooster. And he set up a Saturday clinic in his church. He had physicians and he had pastoral counselors, so that the physicians would be tending to the bodies and the pastoral counselors there were tending to the soul. And the attempt was to have this kind of this holistic movement. The same time, in Cincinnati, Ohio, Edward Keller, a physician, was meeting with with ministers and seminarians at a seminary there to talk about the relationship between faith and health. So there's this, and this arose out of the social gospel movement that was in the latter part of the 19th century and the first part of the 20th century. An incredible minister by the name of Washington Gladden, in fact, wrote a book of case studies where, and this was in 1890, where Washington Gladden was putting together a book of case studies around the issues of persons that he was counseling who also had physical ailments. So this has been part of the fabric, at least in the modern, modern period, that there has been this connection that has been waning. Now, I'm just going to finish up with one more story from my experience. So I went on to graduate school, and that's when I got involved with working with medical ethics in the medical humanities. And before I came to Georgia, I was at the University of Maryland School of Medicine. And I was also a director of ethics consultation for the University of Maryland Health System, which, sort of like Emory, we had 20 hospitals all around the state. And I lived on the eastern shore of the Chesapeake Bay. Anybody been to the eastern shore of the Chesapeake Bay? It is as rural as South Georgia. Chickens, right? And feed corn and rye. So, and it used to be tobacco, of course. Now, I had 5 hospitals on the eastern shore that I was responsible for ethics consultation. And the first thing that I did was to make sure that every one of those hospitals had lunches held with the medical staff and the local clergy. Because as we found, you gotta talk to each other. And when the clergy know, one thing clergy and physicians all have in common, you feed them and they'll come. And that was how we got that conversation going there in the eastern shore of Maryland. So that we really had open lines of conversation about what it meant to be sick, what it meant to be ill, but also what can we do to keep people well and develop the wellness programs, just as has been discussed, that are happening here in Georgia. So that's why when Greg and I, we did not have a bottle of Jack and Black. As he said, it may have been a better program idea. But that's what, when he and I started talking, and actually, and this is where I'll finish, you and I started doing work in one of your courses.
Right.
And so take it off.
Well, thank you, Dr. Childs. This is the first time we've met in person. And we've been collaborating for 3 years. So this is the miracle of the world in which we live. Son of a doctor, son of a preacher man. That's the song I want sung at my funeral. Son of a preacher man. My parents were missionaries in the Philippines. I grew up there. Dr. Childs mentioned the existential crisis that patients face, that for ministers, church members face at the point of illness. My passion has always been for religion itself. Why religion emerged in the first place. What created the need in the human spirit for that thing we call religion. And the reality is religion exists to help us as human beings negotiate boundaries. We need ritual at the point of moving across the boundaries of life. And so, for example, we have a ritual with birth, the birth of a child. Every religion has one. We have a ritual at the point of moving from childhood into adolescence. Every religion has one. We have a ritual at the point of marriage or holy orders, whether you're marrying a spouse or entering the ministry, there's a ritual. We have a ritual at the point of death and transition from life to death. And what I've just named are 4 of the 7 sacraments of the church. And again, every religion has them. So when we come to the point of illness, of the dissonance that comes with being ill, there is this unsettling that we all recognize that sort of dwells in the human spirit. And I think religion is there to help a patient at the moment of that transition from wellness to illness back to wellness again. And both doctors and ministers function at the point of that moment in time. Confessionally, for me, one of my driving passions has always been the fact that I was ill prepared as a minister for the various pastoral care crises that my parishioners were going to face. I think my seminary did its best by me. And now being a professor at a seminary, I know how hard we try and how often we miserably fail at getting our students ready. So part of our collaboration has been at the point of, I teach a course that is entitled, Whatever Happened to Abram's Children? And the course is about Judaism, Christianity, and Islam. And we bring a Muslim chaplain, a Jewish rabbi, and of course Paul joined us for the last class session that we did together for future ministers and future doctors to hear from each other about the care of patients of other religious traditions that's perhaps different from that of the student, or how as a doctor to value the faith experience of a patient. And one of the reasons I'm so passionate about that is because of just how ill-prepared I was for those first calls as an associate pastor or a pastor, when suddenly you're called because there's been a head-on collision and the grandson of church members is in the hospital and you've got to go. Nothing can prepare you for that. And you put on top of that attempts at suicide, you put on top of that cancer, and you're just constantly entering into hospital contexts to help your parishioners make sense of what is happening to them. And early on, I realized how unprepared I was for that. And it's been a constant journey of learning for me. I've been in ministry even as I've been in the academic world throughout, but constantly learning about who to be in the hospital room as a minister and trying to figure out, you know what ministers feel like sometimes? They feel like they're the pooper scooper at the end of the parade. The pooper scooper at the end of the parade. Kind of put that in your brain for just a minute. The doctor comes in the room and says, this is the terrible news, so sorry it's happened. Glad your pastor's here. You got any questions? No? Okay, we'll turn it over to him now. And the minister starts scooping the stuff up around the room, trying to put it back together. From the standpoint of ministry, to have a doctor who recognizes the vital role of the minister in the process, and who says something like, Pastor, would you pray for all of us before I go, would be a very, very powerful thing. And we do have this great biblical story where we meet, right? The story of the Good Samaritan. That is a powerful story of healing, both on the part of ministers and on the part of doctors, and we both sort of claim this.
Yeah, I really appreciated Dr. Scoggins bringing up the liberation theology. Because the story of the Good Samaritan really brings up, who is my neighbor? Remember the question, who is my neighbor? Well, who is the neighbor? It was the one in the ditch. Most people say, oh, it's the Samaritan. No, it's the one in the ditch is our neighbor. And that's where we have a calling with healthcare, that the faith community and the healthcare community have a similar calling. And that's the one to the one in need. So we hold that in common. And I think that's just so terribly important. The call of ministry and the call of medicine are callings that we've been called, vocatio, we've been called, and then we profess and declare that we have accepted that calling to take care of the one in the ditch.
Yeah, the power of that Good Samaritan story for me is in the fact that the person who asks the question, who is my neighbor, is trying to limit the number of neighbors. To whom am I responsible? Help me know who my neighbor is. And then, of course, Jesus, in Jesus' own inimitable way, goes on to tell the story and then says, who was a neighbor to the man in the ditch? That calling to love the Lord your God with all your heart and mind, soul, and strength, and your neighbor as yourself is an unlimited calling. There's no end to it. That's another place, I think, where ministers and doctors and nurses share something in common. There's no end to it. There's no limit to it. It just sort of goes on and on and on with the next person who has a deep need and illness, the next person who's coming to the office for the appointment.
Yeah. The demoniac. Remember what the demoniac said his name was? My name is Legion. So there's always going to be, the people that we are called to care for, whether we be physicians or physicians of the soul. This afternoon we're going to hear from some clergy who've been getting CPO, clinical pastoral orientation, which is a form of clinical pastoral education and training for clinical chaplaincy. And we'll hear some of their stories. But one of the things that, as I said, I'm interested in the history of this movement. The clinical pastoral education was founded in 1924 in a psychiatric hospital in Massachusetts. It's by a chaplain whose name was Anton Boysen. And Dr. Boysen had 5 psychotic episodes in his life. So he was a patient as well as a hospital chaplain. And his stuff is still in print. Explorations of the Inner World, which is a remarkable text. And Out of the Depths is his biography. But Explanations of the Inner World is his understanding of what the psychotic process is. And he says it's essentially a religious crisis. Because in psychosis, the meaning of the world has disintegrated. And so he argued that what a religious or a theological perspective on caring for the psychiatric patient was, and the term he used was putting a lid on chaos, which is, I think, just a marvelous image. A lid on chaos, because the psychotic experience is experiencing chaos 24/7, 365. Right? So it's powerful images that come out of what we're trying to talk about here today.
That kind of goes back to the spiritual role of kind of setting the boundaries again in the midst of that chaos. I do want to share one experience with you that I have had in my ministry career, which I think might be helpful. When I was in my first full-time congregation, we actually had a doctor who was in the church, a wonderful guy who probably saw half the members of the congregation in his practice. I'll tell a quick little funny story. As it turned out, it was funny. We were putting an elevator in so that our older members could manage to get up to the Sunday school classes that they had, and we were going to have a fundraiser luncheon after church. An elderly member of the church was on her way to the luncheon when she tripped and fell down the stairs on the way to the luncheon about the elevator. So the doctor, Dr. Claude Hazlett, quickly was able to see that the wound was superficial, even though she was really bleeding a lot. And then he kind of looked up at me and said, "Are you sure you didn't push her down those stairs?" We raised $100,000 cash money at the elevator fundraiser. I offer that as a fundraising methodology. No, I don't do that. But it would be wrong. But what I do want to say is that Dr. Hazlett and I became a team together. He was nearing the end of his career in medicine. I was at the beginning of my career in ministry. And he sort of put his arms around me and taught me about the physical care of patients and how, in some ways, that went hand in hand with the spiritual care of patients. So that we were actually consulting together on church members who were facing this kind of illness or that kind of illness. So sometimes there are doctors in congregations who can be huge resources for ministers, or in the community who could you can seek out as a minister to be a sort of guide and help to you. We do want to have some table talk at the tables today. You have a little placard on the table. What we would like to invite you to do is to pick one or two of these questions that seem of interest to you at the table. And the questions are also going to be up here on the screen. I started to say the board. That was from a long time ago. Yeah, share. Perhaps you want to share a story in which a chaplain or pastor has been helpful to those of you who are in the medical profession, or perhaps you want to share the opposite as a minister when a doctor or nurse was helpful to those of you who are chaplains or ministers. You might get into some conversation about whether or not it's appropriate for a physician or nurse to be part of the prayer time around a patient's care. Or then, when are those moments when a physician or a nurse should offer to pray for a patient? Is that something that, as medical professionals, you feel comfortable doing? When is it ethical to do that? When do you feel it might not be an ethical choice? So pick one or two of those. We'll take, all 15 minutes or so, and then we'd like you to report back about some of the conversation that you've had. So on your mark, get set, go.
I might yeah.
All right. Dr. Childs has the microphone around the room. Let's see who would like to go first. If you'd like to share, you might share what question you focused most of your attention on, and then something about your conversation at the table. So don't be shy. Going once.
You're being shy.
Okay, here in the back corner. We'll just start moving around the room here as we.
I feel like this is The Price is Right.
This is the Putnam County table. So we actually took all of our time on bullet number 1. Share a story in which a chaplain or pastor has been helpful to those of you who are medical professionals when caring for a patient. So we talked about that, and Minister Williamson actually helped us to really open up when we are taking care of a patient at the bedside, and to invite the pastors in to pray for the patient. Our job as nurses probably should be a question of, what else can we do to help you? That kind of opens up the conversation and allows the patient to make a decision of whether they want a pastor in, because we don't want to always throw ourselves into, because we are already doing everything we can to help the patient medically, but sometimes we forget that the spiritual part needs to be helped as well. And in order for the patient to get the help that they need holistically, we would have to allow them to ask us to bring in a pastor or a chaplain to help pray for them. And one thing that we did discover as well, which is an issue, sometimes we're more prone to ask that question in the hospital setting. But now that I work in a clinic, we don't ask that question. And they do get bad news in the clinic setting, in the doctor's office. We send them back out into the community, depressed, upset, not even agreeing with the diagnosis that has been given to them. So I feel like we need to somehow put some ministry in the clinic as well, in the doctor's office setting, so that they will still have everything they need at that point. So that's just kind of what we talked about at the Roundtable here at Putnam County. And maybe somebody can help us if you've gotten a pastor or someone in that area that can help in the clinic setting, so that we can help the patients there as well.
I think that's, to ask the question, are you part of a faith community? Just that simple question. It's a non-threatening question, but it gives them the opportunity to, for one thing, tell you about what their church or their temple or whatever means to them, but it also opens up the possibility of other support.
One of the things that I learned early on in my training to become a chaplain was really actually not to pray at all, but to listen, to hear the story. And then there may be prayer after hearing the story, but it's it's listening. What brings you here today? And the patient's going to tell you a story. And it may be a story that the doctor is never going to hear. unless you hear it and tell the doctor and tell her about that story. Look, what table's next? Come on down. Over here? Okay.
Hi, I'm Audrey Kennedy, and I'm a nurse. And the question that we focused on was the last one regarding should a physician or nurse ever offer to pray for a patient and under what circumstances? So we were relating some of our experiences with patients in a period of transition. And I can say near death, pre-death, or what have you, when they were seeing beings that other people couldn't see. And some of them, or either a location what other people couldn't see. So some of the people were receptive to prayer that was offered for them. But one thing that was common with the individuals was either apprehension or anticipation. And we believe it should be offered, whether it's accepted or not. Give them the opportunity to decide whether they want to receive the prayer. Don't just automatically start praying, because everybody, no matter what they're facing, they still might not believe. And that was what the experience was with one of us. This person basically saw fire and brimstone, and they still did not want prayer, but they didn't want to be alone.
Yeah, I wonder, coming from the side of ministry, it occurs to me that often medical professionals would be the only ones in the room. That there wouldn't necessarily be a minister or a chaplain in the room, so you're constantly probably facing, what do we do, what do I do in that situation? I guess.
Well, we talk, first of all, we're also Putnam County.
That's right.
Well, Green, Putnam, Waco County, Georgia. No, but we talked about really the sincerity of it also. I've experienced as a physician multiple times where we are alone with the patient, and I think knowing the patient helps a whole bunch. As a family physician, it's a whole lot easier than a neurosurgeon that doesn't really know the patient. And knowing whether they will accept it or not, or asking, can we pray together? It's really nice when they're church members of yours, or you're familiar with them. That helps. And what was the comments that were being made were, they've been in situations where physicians just automatically pray a kind of a automatic prayer, and that's just that's not helpful. That almost is insincere. Almost makes you question it, versus one that tells you a really heartfelt prayer that makes you bond with that provider. And actually, as was said, it's a pretty good sales technique. I hate to say it, because then they go and tell all their friends how great this provider was, and how sincere and all that. Whereas the other one says, I was a little scared because he just threw out a prayer like he didn't trust what he was fixing to do. And of course, at the end of it, he said, "Don't sue me." But I think the sincerity is real important, and not just doing it because you went to a conference that said you should be praying for patients. And like you said, also understanding the patient, knowing the patient, because there are ones that like you said, they don't want to hear it. They don't want to hear it at all. But I've also been in situations where I was told they came to us because we had God's medicine. And as I told them, that'll really pump you up. If you're walking around knowing you're one of God's servants and people know that, it's pretty exciting.
Yeah, one thing that popped into my head as you were talking, I refer to some ministers as having the Teflon coating. They've done it so much, and the prayer almost becomes the goodbye. You know, they're just going to pray so they can get out of the room. But there is this sort of Teflon, and I imagine that happens with doctors as well.
So we echo some of the same sentiments that have already been shared in the room about the importance of consent. Also, the importance of having the physician-patient relationship and knowing your patients. But we also talked about how, going to the story of Job, and how when he lost everything, his friends showed up and didn't say anything. And how sometimes it's not about finding the words, it's just being present. And so for those medical professionals who don't know the words or feel like they're going to mess something up, sometimes a person just needs you to be present. And in the story, it's not until they opened their mouth that things went south. And so sometimes it's just about, keeping watch or keeping visual with the person, right? And then there's oftentimes too, a person doesn't want to focus on the prognosis or the diagnosis. So it's changing the subject. Have you eaten today, right? And just having some other kind of dialogue with them. And so I think that's also important, that while we focus on prayer, sometimes it is just keeping the silence with them and understanding that the spirits can still communicate even in the silence.
Thank you.
Yeah, they call it interlocutors, which is unfortunate because, well, that's what they ended up doing. They blew it when they started getting theological.
Another table? Sir. Yes.
Good afternoon, everybody. One of the main points that came out as we were talking, and to digress to what one of the gentlemen said, remembering that we are called to the ditch. We're called to people who are in the ditch. And then somebody mentioned legion. So we are called to those who are in the ditch and in the cemetery. So this is not pretty work that we're doing. And I'm thinking of the woman who had the issue of blood, which was a sickness. But she also had other issues. She was broke. She had spent all that she had. Okay, so when Jesus deals with her, he didn't just say, woman, thou art healed. He said, you're made whole. So we have to look at the total humanity of a man, and most of the time, once they leave the hospital, we're done. There's no follow-up. We've done our 2 cents, now blessed be Jesus. But there has to be follow-up to get them not just healed, but whole. Okay, if a dude who got a job and he's been sick for 2 months, his family's struggling if he's the main breadwinner. He needs more than prayer. He needs bread. And we are called to meet those needs. And also another thing that I looked at, I was hearing where we were saying that sometimes they don't want prayer. That's cool. You still can pray. Okay, just because the person say, no, I don't want prayer. I'm like, okay, cool. As soon as I get outside, just tell Jesus. Stop by room 507. Okay, so just remembering my own life, coming along, being raised in church but not saved. And when they were asked, who's not saved, I would be the only one raising my hand. I'd be pointing, y'all need your help, y'all. Putnam County, y'all need y'all help. Everybody here. But I was the only one. And they would ask me, do I want to be saved? And I would say, not today, Reverend. Not today. So the man, he prayed for me. He says, I'm going to pray, even though you don't want it, that the Lord gives you a mind to want to be saved. So we have to do follow up beyond the hospital, and not just to get them healed, but to get them whole.
You say, so the Good Samaritan, he gave him money afterwards to take care of him after he left. That's awesome.
You also remind me that often those in need of prayer ministry are the family in the room, not just the patient in the bed, and the spouse, the parents, grandparents, whoever. How are we doing on time? Okay. Fine.
Okay. We kind of jumped around a little bit, but we, in the second story, they share a story in which a medical doctor or nurse has been helpful to those who are chaplains or ministers when caring for a patient. I just went back to the time when my father was going through with leukemia and the treatment and everything that he was under. God just sent an angel to us, which was a nurse, and she came in and she made sure that he was taken care of. We were traveling back and forth from Edenton to Emory for him to take treatments and everything. She made sure that we got an apartment set up, showed us how to get the funding for it, all these different pieces, and put it all in place. And just so thankful. We were just so thankful for her because it meant so much, because my mother was going through that as well, going back and forth. It was tiring, it was taxing upon her. You could see it wearing on her. But when they were able to get him housing and everything and all the other pieces, and then also helping us with getting everything on the list for him to get what's it called, transfusion or transplant, excuse me, transplant, excuse me, my mind flow right now, but transplant for bone marrow transplant, that's what it was, bone marrow transplant. And all that, all the information on that, she helped so much with that. So that was a blessing there. And then all my friends, Sister Linda here, she was telling us about, she was sharing with us in the third question there, how is it appropriate for ministers to ask for physicians if she could pray for both doctor and patient together prior to a medical procedure, or is it appropriate for a physician or nurse to ask a minister to pray for him or her in such moments? And also, we kind of combined it with, should a physician or nurse ever offer to pray for a patient? We went into that, and she was saying, she was telling when she was going through a certain procedure in her life, that her family, we were in the room praying, and they were already on their knees, and the doctor walked in, and he saw what was going on. He got on his knees. He started praying right there with them. So yeah, I think prayer is always appropriate when everybody's on the same page, when they're, and it's welcomed. It's welcomed. And just as the gentleman said just a few minutes ago, even if it's not, when they go outside the room, we're still praying. But at that moment, that doctor walked in, he saw what was going on. He was a fellow believer. He was, let me get right in there with you. So,
That's great. Thank you. Any table that hasn't shared yet that would like to get, thank you, Brad.
My table threw me under the bus, and they voted on it. Thank you. Yeah, they didn't offer to pray though. We talked about number 3 and number 4, and our consensus was yes, it's appropriate for a minister to ask a physician if he or she could pray for both the doctor and the patient together. We've been in those situations before, but we also recognize that it's important to ask first, because you don't know what their faith journey has been. And as a fellow Northerner pointed out, in the South, a Southern Baptist does not want an Episcopal or a Lutheran pastor to pray for them. Not out loud. You can do it behind closed doors. And unfortunately, it's gotten that way even with the Methodist Church. You've got 2 different arms there, 3, I think. It's sad that we forget sometimes that faith is about faith in a higher being. And for those of us who are Christians, it's important to recognize that we believe in Jesus as our Savior. But that's not the case for the Jew or the Muslim, and to not exclude them. So even to ask, can I pray for you? And then say, I'm a Muslim. Okay, do you want me to find someone who can pray with you? Or if I don't pray in Jesus' name, is that okay? Okay, and we didn't talk about that piece, but that just came right there. And in terms of offering to pray, we've come in that situation too of offering, but again, it can come from either direction, and it's appropriate.
I just wanted to add to that a little bit. This is just a little thing that I learned years ago, and I actually learned it on the ambulance. I think I was coming from Lake Oconee, heading into Grady. Where's the Grady doctor? I strongly still believe in the power of human touch. I think that if you want evidence of it, go into the NICU and look at the babies that are held and touched, you know, and how well that helps them to thrive. So if I have a patient that I don't know and I'm not sure of and I don't know what their status is, I use just a little technique. Well, I'm trying to comfort them with my hand, and I hum. And I hum a little song that I just, you know the song. It's called He Touched Me. And I don't sing the words, I just, or Amazing Grace. Hum it. If you've been to a funeral, or you've been any place around any group of Christian people, at some point in their life, they have probably heard that song. And if they're traveling down I-20 and it's an iffy as to whether or not they're going to make it alive, and they hear that tune, Amazing Grace, being hummed, a lot of them will just say, I know that song. I know I've heard that song. My grandmother used to hum that, or my mother used to hum it, or my aunt, or my uncle, or they sang that at my grandfather's funeral. And then I say, okay, yeah, that's called Amazing Grace. And then that leaves an opportunity for me to be able to say, is it okay if I pray for you? Never. Now, me personally, I can't speak for everybody, but I've never had one in the back of that ambulance, ever, tell me no. Okay? That's my little hint there.
Well, what's interesting about Amazing Grace is it's not overtly Christian. There's no Christology in it, that song. It's a wonderful kind of neutral. Because, I really appreciate your comments because, I don't know what the latest polls say, but the majority of the people in this country have none. And that's really important to remember. We're making assumptions here that we're living in a Christian environment. We're not.
And it's not politically correct to be Christian.
Yeah, I had the experience, my father was in hospice care at Northside, right near Northside Hospital in Atlanta at the end of his life. He was a missionary in a predominantly Muslim island in the Philippines, planting churches, and a Muslim chieftain of the village would give land for a church. It was a kind of easy relationship, but it was a Muslim chaplain who was with him when he died. As a Christian, it says a lot about the world in which we live.
Yeah. It reminds me, no, never mind. She's speaking.
She's speaking. Are you ready?
All right, thank you, everyone.